Hello, my name is Tyler Bonkowski. I'm a second-year cardiology fellow at Corewell Health East in Dearborn, Michigan, and I'd like to present a case report called The Triple Threat, a Rare Cause of Heart Failure. Our authors are listed here, and we have no relevant financial relationships to disclose. L-type transposition of the great vessels, or L-TGA, is a congenital anomaly that results in atrioventricular and ventriculo-atrial discordance and is frequently associated with coronary anomalies. On the right is an image of the anatomy of L-TGA with the left ventricle and the mitral valve attached to the right atrium and pulmonary artery, and the morphologic right ventricle attached to the left atrium and aorta. This anomaly is often referred to as congenitally corrected transposition, as the systemic and pulmonary circuits remain in series. Here we present a unique case of previously undiagnosed L-TGA complicated by severe atherosclerosis and a malignant anomalous coronary artery presenting as new onset heart failure. A 66-year-old male presented to his primary care provider office with 10 days of chest pain, dyspnea, and fatigue. Workup in the ED showed new onset heart failure and NSTEMI, for which he was medically managed with intravenous diuretics as well as heparin and nitroglycerin infusions. Coronary angiography revealed anomalous origin of the left coronary system from the right aortic cusp with obstructive 3-vessel CAD, as shown on the right. Surface echocardiogram demonstrated L-type transposition of the great vessels, septal hypokinesis, and severe biventricular dysfunction. The patient's echo on the right shows a heavily trabeculated systemic ventricle with an apically displaced atrioventricular valve, a hallmark of L-TGA. Coronary CTA confirmed diffuse obstructive CAD, with the RCA and LAD arising from a common trunk off the right anterior cusp, and the left circumflex artery arising from the posterior cusp and taking a malignant course between the pulmonary artery and the aorta as it traversed posteriorly. The patient was then transferred to a heart transplant capable center for consideration of advanced therapies. Right heart catheterization showed severely elevated pulmonary pressures and a borderline low cardiac index at 2.2. Cardiac MRI revealed transmural infarct in the basal septum with an estimated systemic ventricular ejection fraction of 35 to 40%. After a multi-specialty heart team discussion, the patient was not a candidate for CABG due to his anomalous coronary anatomy and ventricular dysfunction. His small ventricular cavity also precluded him from a ventricular assist device. He was therefore medically optimized with guideline-directed medical therapy and diuretics and was discharged with plans for an outpatient heart transplant evaluation. L-TGA may go undiagnosed due to a double switch, which results in physiologic blood flow and normal oxygenation, allowing patients to reach adulthood, as ours did. Coronary anomalies make traditional angiography difficult due to atypical origins and oblique takeoffs, making coronary CT angiography an ideal imaging modality for these patients. On the right is the patient's coronary CTA, which also demonstrated a heavily trabeculated morphologic right ventricle, acting as a systemic ventricle, which was seen on his echocardiogram. While small retrospective studies have shown improved intermediate outcomes with anatomic correction in young children, patients with L-TGA ultimately require cardiac transplantation due to systemic ventricular failure. In conclusion, L-TGA is a rare congenital cardiac defect that can be associated with coronary anomalies and CAD. Multimodality imaging and heart team discussions are crucial to guide therapy. Patients ultimately require heart transplantation and should be referred to capable center early. Thank you for your time.